Everyone, and welcome to today's webinar, Trauma Verification's May Q&A web conference. We recommend that you join today's webinar over the telephone. Just select telephone in the audio pane and the dial-in information will be displayed there for you. I would now like to introduce Molly Lozada, Trauma Verification Program Manager. Welcome, Molly.
Thank you, Sarah. Thank you, everyone, for joining today's webinar. It's the end of the month, and we're looking forward to June, actually. So just to introduce our staff, it's just going to be me today. Tammy and Rachel are not participating today, so I'm going to do this on my own. So just some housekeeping rules. So to qualify for CE, you must attend at least 15 minutes of this educational content, this webinar. An email will be sent to all attendees who qualify for CE within 24 hours of the webinar ending with instructions on how to claim those CE. If you have any questions during the entire presentation, please feel free to email us at cotvrc@facs.org. So you'll see this email address throughout the webinar. The goal for this webinar is to interpret the standards outlined in the Resources for Optimal Care of the Injured Patient Manual to ensure that hospitals have an understanding of the criteria to provide quality care to the injured patient. Understand the processes and standards involved in an ACS Trauma Verification site visit and how following these will positively impact the quality of care of the injured patients at your facility. So with that said, let's get started. So for some new members or some new participants joining us, please feel free to have a copy of the Orange Book. If you don't have a copy of that, you certainly can download a PDF copy from our website. The address is noted at the bottom. So one of the things I want to stress, it is important to use not only the manual, but to also use the clarification documents and the verification change log in conjunction with the manual. The reason for that is that the clarification document will provide clarification on some standards, and the verification log will provide changes to any standards that have occurred since the release of the manual. So any new changes will be noted in that verification change log. Again, just want to iterate that we do, or I release a monthly clarification and verification document update. I will be doing one here in the next week or so. And with that, you will either see some changes that resulted in the last month or possibly no changes. So it will be noted in the email that I will send, and that will be sent to our participants. Again, going forward, any changes to the criteria will be noted in the verification change log, and any clarifications to our standards will be noted in the clarification document. And here are just some snapshots of what the differences are in the two documents. This is the clarification document, and this here is the change log. Again, someone had asked me at a seminar recently if we can list all of our standards in one single document, which I thought was a great question. And for those of you that did not know this, this verification change log actually contains all of our standards, and you can filter it, you can unfilter it by level, by criteria, by change, or by the type. So this definitely is a great tool going forward if you want to capture all our changes, or at least all our standards. Recordings of the webinar will be recorded and available on the ACS YouTube channel. You can access that on our resources webpage. As you see here is the link. Just for a point of reference, they are listed towards the bottom of the page, so you'll have to scroll down a little bit. They're not in any particular order, so just if you want to view any of those, feel free to do so. So all questions are pulled directly from the questions submitted through the portal. There have been no edits made to the content of your questions. If your question is not answered today, and the question, so it may mean the question requires more information, or that we received a similar or question from another person, we will follow up with those that we pulled within the next week or so. Just a few announcements. The 2017 TQIP Annual Scientific Meeting will be held here in Chicago November 13th through 11th through the 13th. Sorry about that, November 11th through the 13th. So please go ahead and save the date. Abstract submission will open or were open May 1st of 2017, so you can go ahead and submit that. I believe the hotel is now open for registration. Yes, it is. The hotel reservations are now open, so you can go ahead and visit the TQIP meeting website. And again, just call for abstracts open May 1st. So if you have not submitted that, go ahead and do so at this time. Again, just some highlights from the conference. TQIP will be hosting some pre-conferences, as you see here. There's a detailed listing on the program's workshop address. You have AIS, Injury Scaling Uses and Techniques. It's a 2-day course, so please note the dates. Topic will be offered this year, which for any new participants to our webinar. Topic is great because it does talk a lot about the PI process, especially coming up for a site visit. It kind of talks about techniques and how to capture PI. Optimal course is, you are not familiar with the optimal course. The optimal course outlines what to expect during a site visit, either a consultation, verification, re-verification. Again, this could be for new users, current users, or people who have been through the process many times, but I think it's a great course. And then we're also offering the AIS 15 update. So again, for detail of all these courses, you can go ahead and visit the link that you see here on the webpage. The resources revision process, again, if you're new to our webinar this month, we are now kind of already in the process of looking at redoing or revising or updating the Orange Book, if you will. And what we are doing differently this year is we have now provided a place, what we're calling a Stakeholder public comment website, for anyone actually to go ahead and provide us input, recommendations, any questions or concerns people have about our standards that we currently have or maybe not have in place. So if there's anything that you have an interest or strong interest in, you can go ahead and visit this website and provide your comment on all the chapters. If you're asking us to either add a new requirement or make a change to requirement, we are asking you to help us with some evidence-based documentation or support your change or your recommendation when you submit that. Just want to let everyone know we started with Chapter 6. We are pretty much done with Chapter 6, to be honest with you. We're going to go ahead and finalize that here in the next couple of weeks. So, but the other chapters that are coming up for revision, we're not doing these in any specific order. We're kind of doing them randomly. So the next chapter coming up is Chapter 9, Orthopedic Surgery, and Chapter 10. So Chapter 9 and Chapter 10, Pediatric Surgery. These are the 2 chapters that are coming up. And again, if anyone has any comments on any of these 2 chapters or any other chapters, please let us know. But especially for Chapter 9 and Chapter 10, we are going to start diving into these 2 chapters possibly in the next 2 weeks. So, and again, the Stakeholder Public Comment website will remain open throughout the year until I think we're done, or it's going to be a living place for people to go ahead and provide comments. Again, a new tutorial we just released last month is for any new trauma program managers to the verification process. If you are unfamiliar with our processes and how it works and how the scheduling process works, anything, you know, about when do I submit an application, what is involved in a site visit, what do I need to do to get the process started, or you're just looking for information on what our process or what the verification process is. We developed this new tutorial, which will be a series going forward, but the first one is becoming a verified trauma center, and it's just the first step, as I said, and it's designed for trauma program managers and medical directors who are not familiar with our process and just want some more information So you can definitely take a look at that at your leisure, and the website is noted at the bottom. So some scheduling reminders. As I mentioned, I am filling in for Rachel. Just want to let everyone know, again, the site visit application process requires a 13 to a 14-month lead, and this lead is required for any type of site visit, not focus reviews. Again, we're talking about consultation, re-verification, and verification visits. We need this time just to prepare or to allow the trauma center to prepare their PRQ and for Rachel to go ahead and schedule the visits. You have plenty of time to go ahead and do that. And again, we are pretty much closed. Actually, we are closed for 2017. We are accepting applications for August of 2018 and onward. There is really no other months that we can schedule visits prior to July of 2018. So one of the questions we get constantly is whether or not you can submit your application early. So if you have a visit come or your due date is not until 2019, you can certainly submit your application now. There's no harm in submitting early. So I just want to let people know that. Some additional information will be submitted with your application if you're new to the process. For level 1 trauma centers, adult, and level 1 pediatric trauma centers, you must submit your orthopedic traumatologist leader or the OTL form. There's some questions on there that we're asking you to complete, and that will get reviewed to ensure that your OTL leader has completed and approved OTL fellowship. So really it's just a matter of the office validating that that the fellowship was done. And also, if there are any trauma centers or any applicants out there that need the alternate pathway, you must let us know at that time as well. Again, this is just going into the form a little bit more in detail. For level 1, level 2 trauma centers, the form is located in the site packet link here. And again, for those trauma centers that share an OTL, if it's a level 1 adult and a level 1 pediatric, and you share your OTL, we do need separate forms, but we don't need them entirely completed. One of the 2 centers will have to supply the information, and then we can just kind of reference that form. If you're unsure if you have, or if the other center completed it, you can certainly contact us at the cotvrc@facs.org for confirmation. Again, alternate pathway, just as a reminder, if you have any panel members working or taking trauma calls that are not board certified in the U.S. or in Canada, they must undergo review through the alternate pathway, and there's a process for that. You can visit the website here, the site visit packet website, for additional information. So if you are in the process of submitting your application and you have a non-boarded U.S. or Canadian physician on the trauma panel, you need to supply or furnish us with their name and their specialty, along with a copy of their CV. Pre-review questionnaire, just again, more information. For centers who submitted their applications, you will receive access to your online PRQ in an email, and a confirmation email, and that information will be noted kind of towards the bottom of your email. So some people tend to overskip that, but your login information and your access information will be on there. And I also want to let folks know that we did update our PRQ in Word that are posted on the website. They do match what is currently online. And I do want to say that we've made some recent changes, and I'm sorry I did not create a slide for this, but we did do some recent changes to a few areas. I did send out an email, and I will let you know now that we are making some tweaks along the way just based on some feedback that we received from you all, and we will go ahead and incorporate that and let everyone know in a mass email going forward. Site visit application payments, please do not submit a payment. Your center is going to be invoiced annually, and the invoice will include your TQIP fee along with your annual verification fee. There's a list on the fee structure on the VRC fees website. For more information about your fees and how that will work, please submit your questions to COTVRC at FACS. They can, the operations team can give you a little bit more information on how that will work for your trauma center, because it will differ. Scheduling visits. Visits are typically scheduled within 90 days, as some of you are familiar with. Sometimes it could be done a little earlier. It's just depending on the reviewer's availability. Ideally, all visits will occur during the center's preferred time. So if you provide us a 2-month time frame, which is what we ask for on the application, we will definitely stick to that time period. If you have specific dates that you want us to look at to schedule your visit, you can certainly contact Rachel and let her know that you're looking at specific dates as well. So when the lead reviewer is available for your site visit, Rachel, who is the VRC staff, will contact you to confirm the dates before anything is confirmed. Okay, so we're moving on to general questions here. So we had a question about TQIP and the benchmarking report. So this is a TQIP participant. We are a TQIP participant as of August, but when I get a report to 2018, how do we meet the requirements for the benchmarking? So I just want to clarify that there's really, the only requirement we have for benchmarking is that the trauma center is participating in TQIP. As it says here, in order to meet the CD, which is CD 15-5, again, please refer to the clarification document and the change log, because this is going to differ from the book. The book talks about risk adjustment, but when you look at the clarification doc and the verification change log, we're talking about meeting 15-5 as TQIP. Hospitals must only be enrolled in TQIP. Hospitals are not required to have received a TQIP benchmark report at the time of their verification visit. This is true for re-verification or a consultation visit. We ask that hospitals have their last few TQIP reports, if available, on hand to discuss with reviewers if requested. TQIP reports are a good opportunity for hospitals to showcase your PI process. Hospitals are not being penalized or lauded for the TQIP results alone. TQIP staff provide a summary of the hospital's TQIP results to reviewers, along with an executive summary and explanation of how to interpret the results. So again, reviewers are if you are a TQIP participating hospital and there is a report, the reviewers will receive a summary of that report. They don't receive a whole entire report, it's just a summary. And we also provide them instructions on how to interpret those, because, you know, they're, again, reviewers are going to look to see how you are incorporating your TQIP results into your PI process. Site visit preparedness. During verification, do the surveyors want to see all 3 years' worth of minutes, meeting attendance, physician CME, or do they just want to see the same time block for patient charts? Great question, and we get this quite often. So during the site visit, all data and documentation, with the exceptions listed below, must be reflective of the reporting period, as this person called it, the same block of time as the chart. So aside from that, the only documentation that we're required for a three-year period is going to be for level 1s and 2s, the CMEs for your physicians, for your non-physicians and your liaisons and your trauma medical director. And again, for level 1, we're going to want to see the research publications, and this is true for pediatric trauma centers as well. Question about PRQ and anesthesia. Can you clarify the question, who fulfills the in-house requirement for anesthesia services? It's a PRQ question for a level 2, and this is, true for level 1. So the question is asking who is in-house to cover anesthesia services. And again, that could be anesthesiologists, your residents, or your CRNAs that are covering. So that's the answer we're looking for when you're completing the PRQ. PRQ, tibial washout times. Question about average time to wash out of the open tibial fractures. Can ED washout times be used? So the PRQ question, again, this is one of those that I referenced just a few minutes ago about changes we made to the PRQ because of clarifications over time. So the question reads, average time to wash out of open tibial fracture secondary to a blunt mechanism report as average and range. So we're just looking for an average and a range for this question. And the time, so the response or the clarification says this time to the first operative washout of open tibial shaft fracture from presentation to your ED, so time to formal OR washout. So we're looking for the time when they came to your ED. So that's what we're looking for. And it typically, again, this is a recommendation. It's not a requirement. We're looking for this to occur within an hour. PRQ question, femur pelvic fractures. On the PRQ, can you clarify the chart full category of femur pelvic fractures? Do you want only open fractures for the second line? So I was a little confused about the last question, but what we're asking for is to pull the last 10 cases for the pelvis femur fractures. And this may include unstable pelvic fractures with hypotension and embolization, or exclude geriatric hip fractures that are managed by internal medicine or geriatrics. So that's what we're looking for. And then we also want you to make sure you have all your PI information with each of the charts and applicable guidelines and protocols to those. PRQ, FAST exam, question is it a deficiency or weakness if we use FAST and don't have specialized QI program? We have heard many different things. So I'm not really sure what they've heard across the board, but I do want to stress there are no CDs or requirements regarding FAST exams. The PRQ does ask to describe the QI process for the FAST exams. And again, this is going to vary across all trauma centers. This is used to assess the process, but does not infer that a CD will be cited. So again, no CD. We're just looking to see how those FAST exams are conducted at your facility and who performs them. So I think there's two questions leading to that. PRQ appendices data. In the PRQ appendices, you are supposed to indicate a total number of CMEs or answer yes or no, or whether the CMEs are internal, external. So I'm not sure a lot of you are familiar with our appendices, but there in the appendices there is a column to the far right that is labeled CME. What we're looking for is the number of trauma-related CMEs obtained per physician. So it's not a yes-no question, unfortunately. We do want a number there. And the number has to match either the certificates or transcripts you have on site, or if you have a summary page sheet, it should definitely match what you noted in your appendices. PRQ PIPS plan 16-1. Can you please explain what you are looking for in a PRQ in the PIPS section, question number 7? So question number 7 reads, describe the PIPS plan that includes a comprehensive written plan outlining the configuration and identifying both adequate personnel to implement that plan in operational data management system. So basically what this is it's I know it's very wordy, but what we're looking for is your trauma PIPS plan. I don't know, I think most trauma centers call it the trauma PIPS plan. There may be a different name for this, but that's what we're asking for in this question, is that you provide us a summary of your PIPS plan and how that is written and how it's configured, and is there adequate personnel to implement your plan. PRQ additional appendices. This is something that we've been asked to do, and we will have some available on the webpage here. So for combined trauma centers, the challenge is that in the PRQ, there is only one appendix for each liaison. And we realized that going forward that we're going to have some copies available on the webpage for you to use for either the adult or the pediatric liaison. There's not enough room on there to document 2 liaisons, so I would just recommend noting your adult liaison and then having the additional appendices on site for the pediatric liaison. Verification level upgrading, this is a great question. This actually comes up quite often, and this actually can be relevant to those trauma centers who had a consultation visit and want a verification visit. There's a time expectation in between the two. So the question is, if a center drops a verification level, how long before can they apply to upgrade again? So the response is it's going to be dependent on the trauma center meeting the criteria for a higher 3, this could be the same for level 2, and wishes to seek a level 2 verification shortly thereafter, the center must ensure that it will meet the level 2 criteria at the time of the verification visit. So what this means is that the center who was primarily a level 3 and is now seeking to upgrade to a level 2, they have to have 12 months of data and to be compliant with all the criteria as a level 2. And again, that has to be during the reporting year or during that time period. The reviewers have to see that the trauma center is functioning at the higher level. It can't have 6 months of level 3 and 6 months of level 2. They need to see that it is functionally working as a level 2 or level 1, whatever the level may be. It has to be during a 12-month period. And again, I just want to stress that this is true for any center that wishes to upgrade. So it's a 3 to a 2 or 2 to a 1. Same with pediatric trauma centers. Please note that the scheduling process for these types of visits is the same as any other visit. So the only exclusion is for focus review. But if you're a new center who just had a consultation visit and wants to pursue a verification visit, the same rules apply. You have to ensure that your program is functioning at the level that it's going to be reviewed. It's really important. We've seen too many trauma centers not allow enough time to address any deficiencies or weaknesses presented at a consultation visit or, say, a level 3 that wants to go to a level 2. So you have to allow time to implement those changes and track those changes and, and make sure that you're trending on and reviewing those through the PI process. Question on common criterion deficiencies. Someone asked about common deficiencies, and again, I gave a little bit in the previous slide, but the most common are CME, peer review attendance, universal screening for alcohol use, and loop closure. These are the most common, and again, most of you who've been through our process, reviewers are pretty adamant about holding fast to our rules. So CME, there's a requirement, peer review, there's a requirement, universal screening, again, requirement, and loop closure. These are the most common CDs that we see over time, and it is getting much better, so it's dwindling a little bit. Geriatric patients, question about what are some recommendations from ACS to improve criteria for geriatric trauma and get ED physicians on board? It's a great question, and unfortunately, we do not currently have any geriatric patient criteria. I will say this is on our to-do list for our next iteration of the resources manual, whatever color that may be. We are definitely looking at developing a geriatric chapter. So please, again, if you have any comments or any recommendations, suggestions about geriatric patients, visit our Stakeholder website and provide us with some feedback. So currently the ACS does not mandate geriatric criteria. However, if the center sees a high percentage of these patients, it would be the expectation that they have both geriatric specific criteria and guidelines. So again, if you have a high percentage of these types of patients in your registry or that you're seeing in your ED, the expectation is that you have, as a trauma center, you have developed some geriatric specific activation criteria and guidelines to follow. Surgeon responds, highest activation surgeon required to be present 15 minutes. Is there a defined time for the surgeon to maintain that presence? Never had this question presented before, so the answer is no. There's an expectation that the surgeon is there throughout the resuscitation process. The question does pose that there may be concerns at the center with some PI issues with engagement and commitment to the program. So whoever submitted this question, it may have to look at their PI process and engagement and commitment to the program. Question about specialty times. Why does the ACS look at neurosurgery ortho response times as opposed to times to craniotomy or other treatment times? You know, it's a great question. As we kind of said in previous webinars, we currently we allow the trauma medical director and the orthopedists and neurosurgery surgeons to work on, you know, injuries that they're going to respond to in a timely fashion. But again, if there's anything you want to see revised to these standards, we're asking you to, again, provide feedback to this, and this also will be reflective in the PRQ. So any changes we make to a standard, it is going to impact the PRQ, so it goes kind of hand in hand. So the current requirement is to track the specialist response time for those injuries that are defined. Again, we're just defining, we're asking the trauma center to define what those injuries are going, those injuries that are going to be tracked, and they have to be agreed upon between the trauma medical director, the orthopedic, and the neurosurgeon. And again, one of those can be, as the question alludes to, is tracking when a patient is taken emergently to the OR for any cranial neurosurgical procedure. So again, your institution is the one that's going to define what those injuries are. So we've kind of left that open for you to tell us what that is. This question about what methods do you recommend for dissemination of information from peer review meetings. So this is going to vary among trauma centers. So really the intent is that the information is disseminated either by email or by the hospital's intranet. The important thing to track here is that it is received and it's read, and there is some type of acknowledgement from this. So the method can vary. However, the intent is that the trauma medical director and or those liaisons that attended the meeting provide their panel members the information and have a mechanism to track receipt of that information. Neurosurgery question about if our neurosurgeons only do spine, do they have to meet the same standards as the neurosurgery? The question, so the answer is if the neurosurgeon is only doing spine surgery and does not participate in trauma call, they are not required to meet the same standards. As I read this question, if the surgeon is only doing spine and that's all they're doing, they're not taking trauma call, they are not required to meet the same standards. However, if the surgeon is doing spine and taking trauma call, then that's they're going to be required to meet the same standards. Just want to clarify that. Pediatric patient admission, who should admit pediatric patients minor injury for a level 2 facility that admits less than 100 pediatric patients per year? If the pediatric patient less than 16 years of age meets the NCDS trauma inclusion criteria or your state's inclusion criteria, the trauma service may admit the patient. So I take this one, I read this that the level 2 doesn't have any pediatric physicians, and that's acceptable. That's okay. You're not required to if you're not seeking pediatric verification. So if it's a level 2 adult trauma center that sees pediatric patients, the adult surgeons are the ones that are going to admit that patient. Just a few CD-related questions we'll go over. So CD 4-1, is it okay if the receiving facility has auto acceptance of all trauma patients, or does physician to physician still required? It's what I read. It is still required. There may be some unintentional consequences in auto acceptance. For example, or for instance, if your center knowingly accepts transfers in which you cannot provide definitive care, they may be result in a secondary transfer. You must monitor and review these instances through your PIPS process. So you definitely want to have physician-to-physician contact. Having auto acceptance, again, will have unintentional consequences where, you know, if you have no room or you don't have the services available, then that patient's going to end up being transferred a second time. So if that's the case, you have to make sure you're monitoring those key instances through your PIPS process. It's not ideal. I know it happens, but it's not the ideal scenario. OPPE process, what performance measures does ACS look for in OPPE process? We really don't have any guidelines on what detail OPPE will be reviewed. We're, again, allowing the trauma center to define those metrics. And what we're asking is that it should include the surgeon's performance activities, and again, that can vary. It could include the peer review attendance, meeting that 50% attendance requirement, CME tracking, any corrective action review by the physician, or any PIPS process issues. There are some examples on the website of some OPPE forms, and I am going to get a couple more, so you may see a few more coming up in the next couple of weeks. Question about ATLS for emergency physicians. For ED physicians, what is the technical ATLS requirement? Taken once or be current in it. So this is for level 3. So so this is going to reference all levels. For level 1, 2, and 3 trauma center, physicians who are board certified or eligible in emergency medicine are required to have successfully completed the ATLS course at least once. They don't have to be current. If they are, that's great, but they don't. For physicians who are not boarded in emergency medicine, but they are boarded in, say, internal medicine, family practice, they're pediatricians, they have to be boarded, they have to be current in ATLS. So if you have any panel members working in the ED who are boarded in family practice, internal medicine, they have to be current in ATLS. That is a requirement. Contingency plan, can it be, so the question is, can 8-5, which is the contingency plan, be part of the overarching diversion plan that includes catastrophic failures, or does it have to be separate? The contingency plan must be separate from the diversion plan because they're different. They both play a different role. What I've said here is that if there is an overarching plan, whatever you want to call that plan, you know, and the plan has a dedicated section for the contingency plan and another for the diversion plan, that is acceptable. So again, you can have one overarching plan as long as there's a dedicated area for one, the diversion plan, and a second for the contingency plan. CD 11-33 is this 30-minute time frame from time of consult to first stick. So the response time is tracked from when the call is made requesting the service for the radiologist to arrive at the trauma center. So that's what we're tracking in time response. ICU liaison, can our surgeon who serves as the ICU co-director serve as the ICU liaison also? Of note, we have an ICU intensivist team. For a level 2 and 3 trauma center who have ICU co-directors, they may also serve as the ICU liaison. I know there's a little confusion in the book. One references the ICU liaison and one references the ICU director, but they can be one and the same. We're not asking to have different folks in those roles, but if you do, that's also acceptable. Question about advanced practice providers. Does the ACS limit the function or have an opinion for APPs in an academic trauma center who respond to trauma activations? I don't know if there was another sentence after that, if there was, if you can reach out to me, I'll go ahead and clarify that even further. But for the first part of this, the ACS does not limit the functions of the APPs. I know we've covered this over, I think, every webinar. If you have APPs who are members of your trauma team activation and participate in the care of the trauma patient and provide assessment and interventions, they're required to be current in ATLS. If your APPs are solely present to be scribes or take orders, or they're there for ortho or responding on behalf of ortho, the ortho service or the neuro service, or even anesthesia, the CRNAs, they're not required to be ATLS providers or current in ATLS. So just those folks that are APPs that participate in your tier activations and provide assessment interventions to the trauma patient are required to be ATLS current. Mortality review, a question about, do we have to delay loop closure pending hospital quality mortality reviews on non-surgical admissions? I'm going to assume that's non-surgical admissions. In this response, I would say no. You don't. You have to review all your deaths regardless if they have been reviewed by your center's hospital quality and mortality committee. If you're pending their review, you can certainly add a note to the chart to say that death is pending review by the mortality committee. I mean, any information you can note on that case that is pending review, the reviewer is welcome, because at least it gives them an idea of where that case is in the process. Nursing education, we get a lot of this. Please discuss PACU RN education. What is the expectation for them? Examples of classes. So in an effort not to misguide anyone on classes to take, you know, our manual, our resources manual does not define what training or classes the nurses who are caring for trauma patients need to have. What we're asking trauma centers at this time is that the hospital provide a mechanism to offer trauma-related education to nurses involved in trauma care. So that is really the only CD we have currently in the resources manual. Again, this is where I will stress to our, for those of you that are participating, if you want to see a change in this specific requirement or any other requirement for that matter, but especially for this one because we do get this quite often, is go ahead and provide us some feedback on this chapter, chapter 17 as a matter of fact, is where this lives. Just give us some ideas or some recommendations as to the types of courses you see the nurses working either in the PACU, ED, ICU, PEDS, any of the services. And we'll definitely take that into consideration when we're looking at revising that chapter. One of the things that we did in education is we did partner up with STN, and STN is currently working on, actually our STN liaison, she's our VRC STN liaison, is going to develop some nursing education guidelines, and the study results are still pending, and as soon as we have that, we'll make that, we'll present that to the group. Alcohol screening tool, do ETOH and drug screens have to be tested, i.e. blood or urine, or can a verbal screen suffice? Please clarify. Great question. Currently, we're just asking that there be a screening tool developed and used by the hospital. The center determines what that tool is going to be, whether you're going to use a blood or urine or a verbal screening like CAGE or BAC. I think there's a few other examples on our website. And if the patient screens positive, then there needs to be a brief intervention on that patient. Injury prevention programs. Is there a monthly minimum for injury prevention programs in a level 1 facility? We have not defined that a level 1 or a level 2 or level 3 has to have a monthly requirement on the injury prevention. The requirement speaks to the trauma center having 2 projects on either 1 issue or 2 projects on 2 issues. And again, the trauma center is going to define on how that is going to play out during the either the reporting year or through the verification process. So you can have 2 a year, or it can be ongoing on a monthly basis. That is definitely up to the trauma center to define. So just a couple of questions on CME. We keep hearing that other facilities are being given deficiencies for not having CME on their ICU doctors. We have asked this before, and we're told just the liaison needs to have their CME available. Our ICU physicians are not surgical and are only consulted for medical or pulmonary issues. What exactly do we need to have on them? And then I had a couple of questions on this. So the second part of this question I had, ICU intensivists are consulted for medical management of trauma patients or respiratory management, not to manage their injuries. Very true. So this came up on a recent course that we did, and Dr. Maxson actually led that course, and he is, for some of you who are not aware of this, Todd Maxson is the chair for the verification committee, and he is adamant about this, that for level 1 and 2 trauma centers, the ICU liaison not only has to have external trauma-related CME, but all other physicians, whether that is your intensivist, your hospitalist, who are just there managing their respiratory or just managing their, or even managing their pulmonary issues, have to also either have external CME or internal, or can be met through an internal process. So, so anyone who is seeing a trauma patient in the ICU and are playing an active role in that care, they are required to meet the same standards as the other trauma panel members, again, either through external CME or through an internal education process at your facility. Please provide examples of critical care parts of the CME requirement. For example, would a conference on diabetes and obesity be considered critical care? If the conference course topic is relevant to the management of the trauma patient, it may be counted to meet the CME requirement. So what that means is that diabetes, obesity, spine, or stroke are not acceptable to trauma-related, to be counted as trauma-related CME. So again, the takeaway is that if the course topic, whether that be an online course, a conference that is given, like for example, Clinical Congress or East or West national conferences, if the topic is relevant to the management of the trauma patient, regardless of what the title says, because the title's not always going to say trauma, but if the topic is relevant to the management of the trauma patient, it may be counted to meet the CME requirement. Question about journal article. Please review what documents we need to show as internal CME attendance, for example, reviewing a journal article. So reading journal articles will count as part of the internal education process. There must be a mechanism or documentation, however you want to do this, by which the program can track its process. That being a list of participants who participate in the journal article. Was the information received? Was it read? Some places either have a mechanism to track if it was read, if the document was open, or if it was literally read, they can do a quiz questions, and was the topic trauma related or did it result from the program's PI process? So again, this can be tracked either by a report that you establish, or it can be by any mechanism, actually. Any way you can demonstrate to the reviewers on site that you are doing this and you are capturing this, have a way to document this, and it's trauma related, or it's resulted from your PI process, the reviewers will accept that. CME, is it acceptable to have the non-liaison sign an attestation form that they completed 16 hours of CME? No. So an attestation will not be acceptable for the non-liaison. The intent is that the center must provide documentation either by certificates, transcripts, or again through the documented internal education process and it must be available at the time of the on-site visit. So just having your physician sign off saying that they met the 16 hours is not going to suffice. The reviewers are going to want to see actual certificates, transcripts, or something demonstrating that they did comply with the standard. CME panel members no longer on the schedule. I know we've covered this a couple of times in our webinars. So if a provider is no longer with the organization, but here during the reporting year, do we still need to have their CME? For the on-site visit and the completion of the PACU, the data is reviewed retrospectively, so you know we're looking at the previous 12 months. So if the center had locums or panel members during the reporting year who are no longer present, they're no longer working there, you don't want to list them in your appendices, because if they're no longer there, they're going to come up short in either meeting the CME or the peer review attendance, or in some fashion they're just going to come up short, and what happens is you're going to be cited a deficiency. So it makes no sense to list them. So, so if you have any panel members that are no longer working at the facility but were there during the reporting year, you do not want to list them in your appendices or list them in tracking your attendance requirements for peer review. So just list those panel members that are currently practicing at your facility. Advanced practice providers, the advanced practice providers require CME. No, there are no CME requirements for your APPs or your mid-levels. So that's a good thing. Prorated for new providers. New surgeons, CME prorated is starting September, or review is in December, or still required to have 16 hours of the year. Great question. The prorated requirement for new trauma centers or new providers will be prorated for 1 year at 16 hours of external trauma-related CME for liaisons, or through an internal education process for non-liaisons. Now, with that said, based on when a provider was hired during the reporting year, the prorated amount may vary. For example, a provider that came on 6 months prior to the visit, it will be prorated accordingly to that time frame. So it's going to be a fraction of the 6, so it's going to be 8 hours of the 16 hours. If the provider came from another trauma center, ideally she or he should have CME, so they can bring those over. So again, if you have any new providers that are coming on, we're not talking about just out of residency, but if they came from another facility and coming onto your service, ideally they should have some CME that they can bring over. Teaching ATLS, does it count as for CME credit? Unfortunately, it does not. Teaching ATLS does not grant CME credits. That was done away with several years ago. So that concludes our webinar for today. I want to thank everyone for participating, and look forward to hearing from you for the next webinar. Thank you.
Thank you, Trauma Verification staff, and thank you everyone for attending today's webinar, Trauma Verification's May Q&A web conference. If you have any other questions, please contact COTVRC at facs.org, facs.org. On behalf of Trauma Verification and our presenters, thank you for joining us today, and have a great rest of your day.